Ladies and gentlemen, welcome back to Chapter 6. This is our 6th of 7 chapter. That's right, I got you in the last one. We still got one more to go. But right now we're going to talk about acid-base disturbances. Now, acid-base disturbances is going to begin with metabolic acidosis with increased anion gap. And our first cause is lactic acidosis. That's right, lactic acidosis is our first cause of metabolic acidosis with an increased anion gap. Our next is going to be aspirin overdose. Yes, aspirin will do it, followed by methanol intoxication, followed by ethylene glycol. Yes, ethylene glycol intoxication when someone's trying to kill themselves and suicide attempts, followed by, yes, look at all this, uremia. We're talking about nephrology. How could we get away without talking about uremia? Followed by isoniazid toxicity, and lastly, DKA. These are the 7 conditions that are going to present with metabolic acidosis and an increased anion gap. They're going to present exactly with those pictures. So what are we going to do? Just like with everything we've done so far, whether it be heme, onc, cardio, we're going to tell you what's the same, and then you're going to also find out what's different, because the difference is where they can ask you questions on step 3. So if you know the difference, you can get the points, score well, and put the USMLEs behind you. Now, in lactic acidosis results from any form of hypoperfusion. Hypoperfusion is associated with hypotension. That's right, it could be sepsis, it could be any number of things, it could be shock. Now, in this form of hypoperfusion leading to hypotension, it causes an anaerobic metabolism. That's right, without oxygen, you can't metabolize. And when that happens, you produce lactic acidosis. The way we treat this, treat the underlying cause. If it's any form of shock, correct the underlying shock. If it's sepsis, give vascular tone back with vasopressors. Do what you need to, but treat the hypoperfusion, and then you'll treat the lactic acidosis. The next is aspirin overdose. Now, an aspirin overdose, you actually start by hyperventilating first. You hyperventilate and cause a respiratory alkalosis. Then later you choke off and toxically kill your mitochondria. That's right, your mitochondria get poisoned like Romeo and Juliet. Ugh. The mitochondria die, and therefore you start to lose your ability to have aerobic metabolism. You're going to form lactic acidosis. This lactic acidosis, well, you treat it with bicarb. When I treat it with bicarb, that allows me to correct that acidosis, and then my kidneys can excrete aspirin. That's right, you need to correct the acidosis and aspirin overdose in order to help excrete the underlying problem, which is too much aspirin. And when that happens, the entire circle will break down, and you'll start to overcome it. Now, methanol intoxication leads to formic acid and formaldehyde production. That's right, formic acid and formaldehyde production. And what happens? How is it going to present? An intoxicated guy who's having visual disturbance. Intoxicated guy with visual disturbance, because formic acid is actually toxic to the retina. Formic acid is toxic to the retina. What are you going to give him? You're going to give him fomepizole or ethanol. Remember at House MD, they started doing shots. Well, we're not going to take shots. You're going to get an IV. Fomepizole and ethanol. You start taking the fomepizole and ethanol. Why? Because it's actually a bridge to the most accurate therapy. That's right. It's a bridge to the most accurate therapy because it blocks the production of formic acid, which allows you to have time to get to the dialysis unit. Dialysis is the only way that you can actually remove the methanol. The fomepizole or the ethanol is actually just a bridge. You're only buying time. Ethylene glycol, well, this is an intoxicated patient with a renal abnormality. What are you going to see? Well, you're going to see oxalate crystals in the urine analysis. Oxalate crystals are going to be the urine analysis, and they're going to have, boom, hypocalcemia, because oxalate and calcium go together. They just love each other. They have a torrid love affair. And what happens is they start to bind together to form crystals. Most commonly, it's presented as part of a suicide attempt. So what are you going to do for these patients with ethylene glycol poisoning? Well, you're going to do the same thing. You're going to treat them the same way as methanol poisoning. You're going to give them fomepizole or ethanol. Why? Because this blocks the formation of oxalic acid. Before, it was to block the formation of formic acid. We're going to block the production of oxalic acid. But again, we're not taking care of the underlying cause. The underlying cause is you have to get rid of it through dialysis. That's right. By using dialysis, you can remove the ethylene glycol that's in the system and eventually break the circle of negativity and evilness that's caused by ethylene glycol. Now, we could never get away with a nephrology chapter without talking about uremia. Now, uremia, well, renal failure, believe it or not, produces somewhere around 1 milliequivalent per kilogram of organic acid. That's right, we produce so much organic acid. If I'm 70 kilograms, I'm going to produce 70 milliequivalents of organic acid. That is a lot, and this is one of the indications for dialysis. If you have overwhelming uremia, you must dialyze the patient. Otherwise, they're going to succumb to the metabolic acidosis. Now, Patients who are suffering from tuberculosis, in terms of latent tuberculosis, they're going to be treated with isoniazid and B6. But isoniazid toxicity is actually a big problem. And how do you treat this? What are they going to see? Well, they're going to have to tell you the patient's on isoniazid. They're going to have to tell you that there's metabolic acidosis with an anion gap. And they're going to have to tell you it's toxic. How? Because they told you the metabolic acidosis and the anion gap. And they're already on INH. They can't really trick you with this one. But the beautiful thing about it is, so they'll do it on the CCS. And what do you do on the CCS? You very simply say, stop the offending agent, which is the INH, the isoniazid, and then you move the clock forward. As soon as you turn that clock, boom, the case is over. If it's your last case, congratulations, you're done with the USMLE Step 3. Now, diabetic ketoacidosis, we've seen it. Yes, diabetic ketoacidosis. If you're an intern, you're going to see it if you haven't already. If you're a resident, you've probably already seen it. And if you're a graduate, you have not gotten through med school or through any training without seeing DKA. DKA is a big problem. Now with DKA, where do you get the acidosis from? Well, you get it from the formation of acetone, acetoacetate, and beta-hydroxybutyric acid. These cause an increase in your anion gap. Additionally, it tells you that you've got a low bicarbonate. That's right, all these acids cause a low bicarbonate. That low bicarbonate, believe it or not, is the single test to tell you whether or not it's life-threatening or not. If you see that low bicarbonate, you've got a problem. And how do you treat diabetic ketoacidosis? We know that it's hyperglycemic state. So what do we got to do? We got to close the gap. We close the gap with IV hydration and insulin. IV hydration and insulin, 2 large bore IVs. Get the fluid in there. Watch the potassium levels as well, because remember, when you start giving insulin, it's going to go into the cells. You're going to get hypokalemic. We've all seen this in the wards. Remember, on the boards, they want you to know about the anion gap and the metabolic acidosis and the 3 kinds of acids they make. That's right. Acetone, acetoacetate, and beta-hydroxybutyric acid. And what is the single best initial test to tell you whether it's life-threatening or not? The low bicarbonate level. Last thing you want to do for the DKA patient, put them in the ICU. Yes, if it's a CCU, do not admit them to the floors. You're going to get it wrong. Make sure you put them in the ICU, and then the case will end. Now, metabolic acidosis with a normal anion gap can be either diarrhea or a renal tubular acidosis. Oh, God. Renal tubular acidosis, yes. Renal tubular acidosis, yes, we're going to talk about it. Oh no, Dr. Sampal, what are we doing? Yes, we're going to talk about it. And after this, you'll never be worried about it. Now, diarrhea. Diarrhea sucks. Diarrhea is a terrible thing. If you've ever had it, you know it's a terrible thing. Now, when you have diarrhea, you're going to have an increased bicarbonate loss from the colon. That's right, increased bicarbonate loss from the colon, because the colon secretes bicarb and potassium. So guess what? They're also going to be hypokalemic as well. So what are you going to do? Well, the body reflexively actually starts to pull in too much chloride. That's right. When you have diarrhea, you lose potassium, you lose bicarb, but you reflexively hold on to chloride. That's why you don't have an anion gap. Otherwise, it would be a metabolic acidosis from the lack of bicarb and an anion gap. But the chloride gets resorbed and it offsets your anion gap. Now, renal tubular acidosis. Renal tubular acidosis type 1 is an inability to excrete acid or hydrogen ions in the distal tubule, far down that way. Yes, the distal tubule. So you have an accumulation of acid. The urine pH begins to rise because you cannot excrete the acid. You can't get rid of it. So what happens? Your urine is alkaline. And remember, alkaline urine causes precipitation of sediment into stones. Therefore, in addition, your serum potassium is going to be low. Now, when this happens, your body can't get rid of the potassium because it can't get rid of the hydrogen. Remember, they go together. So you test these patients by giving them ammonium chloride. You give them an acid. And what happens is normally it should lower the urine pH. But what happens with people with distal RTAs, they can't excrete the acid and the urine pH stays abnormally basic. That's RTA. How do you treat them? Give them bicarb. That's right, give them bicarb. What happens is the proximal tubule is still working, so they'll absorb the bicarbonate. Now, in proximal type 2, you can't reabsorb bicarb at the proximal tubule. Initially, you have an elevated urine pH. When the body loses lots of bicarb, the urine pH starts to drop, and the urine pH becomes low. Then, the low urine pH doesn't make stones, but the low serum bicarbonate also causes a problem. It causes calcium to pull out of the bones, and osteomalacia can occur. You test them by giving them bicarb. In a normal person with an RTA that's proximal, these patients will have metabolic acidosis and they will absorb all the bicarb in a normal person. Therefore, their normal persons will have a low urine pH because they're absorbing it. But remember, in proximal RTA, they can't absorb the bicarb. So in proximal RTA, the urine pH will drop after giving the bicarb. So now what are you going to do? For treatment of proximal renal tubular acidosis, give them a thiazide diuretic. It results in volume contraction, and volume contraction is going to cause your blood volume to raise relative in the serum bicarbonate. You're contracting, so the amount of bicarb that's around will seem like it's much more effective because it seems like it's much more around. You're going to relatively raise the serum bicarb by contracting the volume. And this volume contraction will then lead to increased levels of aldosterone. Now, in the type 4 RTAs, type 4 is a hyporenemic. This is the first time I'm saying that word. No, I'm just kidding. Hyporenemic, hypoaldosteronism, type 4. In this, you have a decreased aldosterone production and a decreased aldosterone effect. So what you want to look for is a diabetic with a normal anion gap metabolic acidosis, and they're going to have a concurrent decreased aldosterone production and a decreased aldosterone effect. And because the aldosterone is not working, they're not holding on to the hydrogens and spitting out potassiums. Nope. They're holding on to potassiums, and you're going to have the only RTA that's ever available with high potassium. So if you ever see a high potassium, click type 4, move on. And you treat them, that's right, aldosterone. Give them an aldosterone agonist like fludrocortisone. Now I'm going to step off the screen here. We're going to summarize all the RTAs. Now, this is a beautiful slide because right now you can see right off the bat which one is different and which one is not. In type 1 RTAs have the only RTA in which the urine pH is high. So you can distinguish it based on that. Serum potassium is only high in type 4 RTAs. So you can distinguish it based on that. Type 1 RTAs are the only ones that give you stones. Now, testing for them. In a type 1 RTA, you give them acid and you treat them with a base. In type 2 RTAs, you test them with a base and you give them a thiazide diuretic and a high dose of bicarb. Type 4 diabetes, well, you look at the urine sodium and you're going to see that there's a great deal of loss, and it's the only one that you treat with fludrocortisone. Notice how this is like Sesame Street. Which of the following is unlike the other? Going each RTA at a time, you're going to notice that there's one thing that stands out that's different. And memorize that one particular component, and you'll be able to cinch the diagnosis on the exam. Now let's talk about the urine anion gap. The urine anion gap actually helps us distinguish between diarrhea and renal tubular acidosis as the cause of the normal anion gap metabolic acidosis. The urine anion gap is your urine sodium subtracted by your urine chloride. Now, when acid is excreted from kidneys, it goes out as NH4Cl. The acid is excreted out along with chloride. Now, the chloride level in the urine is equal to the acid amount, 1:1. So if you can't excrete the acid from the kidney, the urine chloride is going to go up. If the urine chloride goes up, your urine anion gap is going to be negative. However, in diarrhea, then you have a negative urine anion gap. In negative urine anion gap means your kidneys are working. Therefore, you don't have an RTA. Now, if you can't excrete the acid from the kidney, your urine chloride goes down, and this gives you a positive number, simple subtraction. Therefore, RTAs cannot excrete acid from the kidneys, urine chloride is going to be low, and bam, your urine anion gap is positive, and now you know you're dealing with an RTA. Now let's talk about metabolic alkalosis. Metabolic alkaloses are associated with volume contraction. This is because of secondary hyperaldosteronism. It's also associated because of an increased urinary loss of the acid. So how do you treat them? You treat the underlying cause. Treat the underlying issue, you'll get rid of your metabolic alkalosis. Some other associations with metabolic alkalosis you must know. Hyperaldosteronism causes urinary acid loss. Remember, I told you, aldosterone causes you to hold on to sodium and spit out potassium and hydrogens. But if you have too much of that, you're going to lose too much hydrogen, like Conn syndrome, and you're going to have a metabolic alkalosis. Primary hyperaldosteronism or Conn syndrome. Cushing syndrome is another form in which you're going to have hyperaldosteronism. And lastly, you have to worry about one particular component here. You have to surgically remove the adenoma that's causing that. You also have to look for hypokalemia with hyperaldosteronism, as in Conn syndrome, because remember, you're also going to be peeing out hydrogens and potassium ions. Now let's also talk about the hypokalemia. Why does this happen? Again, potassium ions shift out of the cells to correct the hypokalemia because it is in different acid-base state. The hydrogen ions shift into the cell to exchange for potassium ions leaving. In addition, aldosterone is not working, and so what ends up happening is you lose it from the urine as well. Now, in milk alkali syndrome, metabolic alkalosis occurs from too much liquid antacid. That's right. Taking too much, chugging too many Mylantas, and you're going to get a metabolic alkalosis just from that. Vomiting will do this because you're going to lose a lot of acid from the stomach, and volume contraction occurs because you lose a lot of fluid from the vomiting, and you get a secondary hyperaldosteronism. Ladies and gentlemen, that ends the 6th chapter of nephrology. This time, I'll see you in chapter 7 for the final one.